Welcome to the first in a series of lectures on pediatric cardiac anesthesia. In this introductory lecture, we will explore the epidemiology of congenital heart disease and the physiology of fetal, transitional, and adult circulations. We will then explain how to classify CHD and briefly outline important physiological concepts including pulmonary hypertension, cyanosis, ventricular failure, and arrhythmias. Epidemiology. CHD is the most common birth defect and is globally estimated to be 0.8% of births. Its prevalence continues to increase. The survival rate to adulthood of children operated on for congenital heart defects is on average 80% for complex heart disease and at least 98% for simple cases. Infant mortality is the highest in countries with a low socio-demographic index, such as Oceania, North Africa and the Middle East, the Caribbean, Central Sub-Saharan Africa and Southeast Asia. Although countless defects may have been described, 3/4 of them involve the following abnormalities: ventricular septal defect, 26%, persistent ductus arteriosus, 14%, ASD, 11%, tetralogy of Fallot, 9%, pulmonary stenosis, 8%, coarctation of the aorta, 6%, transposition of the great arteries, 6%, and aortic stenosis, 5%. Congenital heart disease must be considered as a systemic disease, because it is associated in more than a quarter of cases with a host of malformations of the skeleton, central nervous system, respiratory system and of the liver and kidneys. In Singapore, the incidence of CHD is 0.81% of total live births. The current estimated number of adults with CHD is in the region of 12,000 adults. An additional 300 to 320 children are born with CHD annually, assuming an annual birth of 37,000 to 40,000 newborns. We will now move on to the physiology of different types of circulations. The 5 circulations we will discuss are the fetal circulation, transitional circulation, adult circulation, shunts, and single-ventricle circulation. The fetal circulation comprises of 3 additional circulatory channels. The ductus venosus connects the umbilical vein to the IVC, allowing blood to bypass the liver. The foramen ovale is located between the left atrium and right atrium, allowing blood to bypass the lungs. The ductus arteriosus connects the pulmonary artery to distal aorta, allowing blood to bypass the left atrium. These 3 fetal circulatory channels shunt blood away from the lungs, such that both ventricles pump blood into the systemic arterial system in parallel. This permits normal fetal growth and development even in fetuses with cardiac malformations. However, delivery of oxygenated blood may be compromised in utero by cardiac lesions that prevent or reduce left ventricular output. Oxygenated blood from the placenta returns to the fetus via the umbilical vein. 50% of umbilical venous blood bypasses the hepatic sinuses and enters the IVC via the ductus venosus. The remainder of the umbilical venous blood passes through the liver and enters the IVC via the hepatic veins. The IVC blood enters the LA during 80% of the cardiac cycle. The other 20% and the overwhelming majority of superior vena cava blood crosses the tricuspid valve and enters the RV. Blood from the RV is ejected into the pulmonary artery. 90% of this is shunted to the distal aorta via the ductus arteriosus. As a result, 2/3 of the total fetal cardiac output is provided by the RV, with the remaining 1/3 provided via the LV. When the baby is born, the low-resistance placenta is removed, resulting in a marked increase in systemic resistance, and alveolar ventilation is initiated, causing a marked decrease in pulmonary resistance. During the next few hours to weeks, the ductus venosus, ductus arteriosus and foramen ovale close. In addition, there are dynamic alterations in pulmonary circulation, myocardial performance and cardiac output. Because of these considerable circulatory changes occurring, 50% of neonates born with CHD will become ill enough during the first days or weeks of life to require medical or surgical intervention. Most neonates that are critically ill from CHD have one or more of these inciting factors at the time of presentation. Hypoxia, acidosis, hypothermia, hypercarbia, or stress increase pulmonary arterial pressure and cause a reopening of the shunts and persistence of the fetal circulation. In some instances, the persistence of fetal circulatory channels may be beneficial or even mandatory for survival. Functional closure of the ductus arteriosus occurs within 24 hours due to increase in oxygenation and decrease in prostaglandin levels. Permanent closure occurs in 2 to 3 weeks. During this period, weak left-to-right flow continues. If the ductus arteriosus remains open, this leads to a shunt, whose direction depends on the ratio between systemic and pulmonary pressures. It may be left to right in case of an obstruction to the pulmonary flow, such as in pulmonary or tricuspid atresia, or right to left if the obstruction concerns aortic flow, such as in aortic hyperplasia or coarctation. Because functional closure is a reversible event, the use of prostaglandin infusions stabilizes neonates with ductal-dependent heart lesions. In instances where there is delayed functional closure and it is disadvantageous, prostaglandin inhibitors such as indomethacin can be used to promote ductal closure. This figure shows surgical ligation of a patent ductus arteriosus via thoracotomy. In Figure A, the PDA has been dissected and secured. Figure B shows a ligated PDA. Cessation of umbilical flow causes a decrease in venous return and a decrease in right atrial pressure. Ventilation causes an increase in pulmonary arterial and venous blood flow and an increase in left atrial pressure. This causes functional closure of the foramen ovale within 24 hours. In 30% of normal adults, the foramen ovale may persist. Anything that increases pulmonary pressures can cause a right-to-left shunt by this orifice. Even in the absence of pulmonary hypertension, coughing or a Valsalva maneuver can raise the pressure of the right atrium sufficiently to cause a right-to-left shunt, thus explaining the occurrence of paradoxical embolisms. The ductus venosus is not as sensitive as the ductus arteriosus. It functionally closes within 1 week and anatomically closes by 3 months. The artery and umbilical vein also close shortly after birth. The fetus has a low pulmonary blood flow secondary to a high pulmonary vascular resistance. At birth, alveolar ventilation commences. The reduced mechanical compression of small pulmonary vessels and increase in arterial oxygenation causes a dramatic reduction in pulmonary vascular resistance. Over the following months, remodeling occurs, such as thinning of the medial smooth muscle layer. By 6 months, pulmonary vascular resistance reaches normal adult levels. In children with CHD, this postnatal pulmonary maturation may be significantly altered. Those with a left-to-right shunt causing a significant increase in pulmonary flow, or those with the presence of any of the inciting factors listed in this table, can retain very muscularized arterioles and permanently high pulmonary resistances. The pulmonary vascular bed is particularly reactive. A vasospastic paroxysmal pulmonary crisis is easily triggered by any phenomena which increases pulmonary vascular resistance, and can occur without warning signs. This table shows the differences between the neonate and adult cardiovascular system. Firstly, the neonatal heart has a limited preload reserve. Augmentation of stroke volume via the Frank-Starling mechanism is limited compared with an adult. As can be seen in this image, the shape of the Frank-Starling curve is different from that of an adult. The slope of the ascending part is very steep, which means that systolic volume is strongly dependent on preload. But the curve reaches its plateau very quickly at around 5 to 8 mm Hg, from which point an increase in preload is no longer causes an increase in systolic volume, but only an elevation of filling pressure. Secondly, the neonatal heart has reduced contractile capacity. Neonatal cardiac cells contain more water and fewer contractile elements. In addition, there are fewer mitochondria and sarcoplasmic reticulum that make the myocardium more dependent on extracellular calcium. Cardiac output essentially depends on heart rate, because the stroke volume is relatively fixed and a neonatal heart operates at 95% of its maximum performance. Thirdly, the neonatal heart is more susceptible to afterload mismatch, and therefore the stroke volume is poorly maintained in the face of increasing outflow resistance. Ventricular compliance is reduced due to a deficiency of elastic elements. In addition to reduced ventricular compliance, at birth the right ventricle and left ventricle are of equal mass until 6 months. Thus, a failure of one of the ventricles, accompanied by an increase in its end diastolic pressure, causes a displacement of the septum which restricts the filling of the other cavity. Failure of a ventricle quickly leads to biventricular congestive failure. Sympathetic innervation is incomplete and hence the vagal response prevails in a newborn. The density of beta-1 receptors is poor and alpha-1 receptors predominate. The decrease in beta receptors explains the better efficacy of adrenaline due to its alpha-1 effect, and of milrinone which acts independently of beta receptors pathway when compared to dopamine or dobutamine. Lastly, the neonatal myocardium is more dependent on anaerobic metabolism, and this may have a somewhat protective effect, making it more tolerant to the effects of hypoxia. Shunting is the process whereby venous return in one circulatory system is recirculated through the arterial outflow of the same circulatory system. The primary goal in the management of children with shunts is to balance the pulmonary blood flow, or QP, and systemic blood flow, or QS, and achieve a QP over QS ratio close to 1:1. Recirculation of systemic venous blood produces a right-to-left shunt, and QP over QS is less than 1. Recirculation of pulmonary venous blood produces a left-to-right shunt, and QP over QS is more than 1. Anatomic shunts exist when there is a communication between pulmonary and arterial vessels or heart chambers. Physiologic shunts exist in the absence of anatomic shunts. An example of physiologic shunt exists in transposition of the great arteries, where there is parallel recirculation of pulmonary venous blood in the pulmonary circuit and systemic venous blood in the systemic circuit. Unless there are one or more communications to allow intercirculatory mixing, such as an ASD, PFO, VSD or PDA, this lesion is incompatible with life. Shunts have 4 main characteristics. Firstly, its direction can be left to right, right to left, or bidirectional. Secondly, its size can be restrictive or non-restrictive. In general, the larger the shunt, the more its blood flow is dependent on the ratio between pulmonary vascular resistance, or PVR, and systemic vascular resistance, or SVR. In restrictive shunts, flow through the orifice is more or less fixed and minimally affected by changes in the ratio between PVR and SVR. This type of shunt keeps a stable hemodynamic significance, varying little during anesthesia and surgery. In non-restrictive shunts, the ratio of PVR to SVR determines the magnitude of shunting. Shunts in the ventricles, such as a VSD, and arteries, such as Ductus arteriosus and Blalock shunt, are dependent on the ratio of PVR to SVR, while shunts in the atria, such as an ASD, are more dependent on the respective compliance of the right and left cavities. In extreme cases, when the shunt is very large, bidirectional shunting occurs, resulting in complete mixing and a functionally common chamber. A third characteristic of a shunt is its complexity. In complex shunts, there is obstruction to outflow in addition to a shunt orifice. Obstruction may be at the valvular, subvalvular, or supravalvular level. Obstruction may be fixed, such as in stenosis, or variable, such as in dynamic infundibular obstruction. An example of complex shunt is tetralogy of Fallot, seen in this picture. There is a fixed component of right ventricular outflow obstruction secondary to infundibular, valvular and possibly supravalvular obstruction. A dynamic component of right ventricular obstruction is produced by spasm of the right ventricle infundibulum. These two components of right ventricular outflow obstruction produce a right to left shunt. A complex shunt can be further divided into partial and complete obstruction. When obstruction is complete, for example in pulmonary atresia or aortic atresia, the shunt pressure gradient is determined only by the shunt orifice. In incomplete obstruction, such as tetralogy of Fallot, increases in pulmonary vascular resistance will also increase right ventricular outflow resistance and increase right to left shunting. Lastly, a shunt is associated with dilation of the receiving chambers and overload of the downstream ventricle. As seen in Figure B, a shunt in the ventricular or arterial area causes left to right flow during systole. This primarily causes volume overload of the LV, which is the pump driving blood flow through the shunt. As the pulmonary valve is open, the RV operates as a passive conduit and does not dilate. Only the gradual increase in PVR causes a secondary pressure overload of the RV. In contrast, a left-to-right shunt situated upstream of the atrioventricular valves, such as an ASD or anomalous pulmonary venous return, creates a volume overload for the RV, which must pump the increased volume into the pulmonary artery. As seen in Figure A, the apex of the heart is formed by the RV and not the LV. This RV volume overload is well tolerated for 2 to 3 decades. A single ventricle circulation is either a natural or palliated situation where blood to the pulmonary circulation is supplied in parallel to the systemic circulation by the same pumping chamber. This can exist in 3 forms. Firstly, where there is only one well-developed ventricle, or true single ventricle anatomy. In the case of a single anatomic ventricle, there is complete obstruction to inflow or outflow from the hyperplastic ventricle, resulting in obstruction to either pulmonary or systemic blood flow. Flow is maintained by natural shunts such as Ductus arteriosus or major aortopulmonary collateral arteries, or artificial systemic to pulmonary artery shunts such as a Blalock-Taussig shunt. A single ventricle circulation may also exist as two-ventricle anatomy with obstructed pulmonary or systemic outflow such as pulmonary atresia, aortic stenosis or coarctation. Flow is maintained by natural or artificial systemic to pulmonary artery shunts as mentioned previously. Finally, there can exist two-ventricle anatomy with unobstructed pulmonary or systemic outflow, but large, non-restrictive intra- or extracardiac shunt lesions. All patients with severe hyperplasia of one ventricle will ultimately be staged down the single ventricle pathway to Fontan physiology. This involves an initial palliative procedure usually performed within the first week, such as the Norwood procedure in hyperplastic left heart syndrome, followed by a bidirectional Glenn shunt, and finally a Fontan procedure that creates a total cavo-pulmonary connection. Patients with single ventricle physiology and two well-formed ventricles may be able to undergo a biventricular repair. Figure A shows the Norwood procedure, which is the first stage in the formation of a single ventricle circulation in patients with hyperplastic left heart syndrome. Label 1 is the modified BT shunt, a surgically created conduit between a subclavian artery and the pulmonary artery. Label 2 is the atrial septoplasty. Label 3 is the ligation of PDA. Label 4 is the creation of neo-aorta. This provides systemic perfusion and allows normal maturation of the pulmonary vasculature, while preserving the function of the single ventricle. Figure B shows the second stage, which is the formation of a bidirectional cavo-pulmonary shunt, also known as a Glenn shunt. This procedure is usually performed at 3 to 6 months of age and connects the superior vena cava to the right pulmonary artery. Any residual BT or other shunts are removed or ligated. Venous return via the inferior vena cava mixes with fully saturated blood in single ventricle. The child remains cyanosed after this procedure with oxygen saturations of 75 to 85%. Figure C shows the third stage, which is the formation of a total cavo-pulmonary connection, also known as Fontan circulation. The inferior vena cava is connected to the right pulmonary artery, thereby separating the pulmonary and systemic circulation and normalizing arterial oxygenation. This is usually performed between 3 to 5 years of age. Pulmonary blood flow is dependent on the pressure gradient across the lungs. The single ventricle provides kinetic energy for systemic blood flow. We will now outline the classification of congenital heart disease. A functional classification of CHD is the most practical approach as it helps one to understand the hemodynamic consequences of the anatomy lesion. Duct-dependent lesions present in the neonatal period and require urgent care. A patent ductus arteriosus is essential to maintain either systemic or pulmonary flow. The majority of defects presenting later in life or requiring later care are classified into one of 5 categories: left-to-right shunts, right-to-left shunts, bidirectional shunts, obstructive lesions and regurgitant lesions. In left-sided ductal-dependent lesions, the patient is duct-dependent for systemic blood flow and the shunt is right-to-left, such as HLHS, interrupted aortic arch, critical aortic stenosis and critical coarctation. In right-sided ductal-dependent lesions, the patient is duct-dependent for pulmonary blood flow and the shunt is left to right, such as pulmonary stenosis, pulmonary atresia, tricuspid atresia, and Ebstein's anomaly. Left-to-right shunts cause an increase in pulmonary blood flow, such an atrial septal defect in Figure A, ventricular septal defect in Figure B and patent ductus arteriosus in Figure C. Not all patients with left-to-right shunts are acyanotic. When the QP to QS ratio is greater than 3:1, delivery of oxygen falls even if the arterial blood is sufficiently oxygenated, and there is a risk of cyanosis. Right-to-left shunts result in decreased pulmonary blood flow and cyanosis. Pulmonary blood flow is dependent on the ductus arteriosus. 2 examples of this are tetralogy of Fallot as shown in Figure A, and tricuspid atresia as shown in Figure B. Bidirectional shunts occur if the orifice is wide and the pressure gradient low, where blood may flow in one direction during systole and in the other during diastole, or may vary according to SVR, PVR, and respiratory pressure. Examples of this include truncus arteriosus as shown in Figure A, and transposition of the great arteries as shown in Figure B. Obstructive lesions include coarctation of the aorta, mitral stenosis, cor triatriatum, aortic stenosis, and interrupted aortic arch. They are usually acyanotic and are characterized by diastolic dysfunction, threat of systolic dysfunction, threat of myocardial ischemia. This picture shows coarctation of the aorta, which is a congenital narrowing of the aorta, usually situated between the origin of the left subclavian artery proximally and the junction of the aorta and the ductus arteriosus distally. Regurgitation lesions include mitral, aortic, tricuspid or pulmonary regurgitation. They can cause eccentric ventricular hypertrophy with volume overload and increased filling pressure, and are exacerbated by rising ventricular afterload. In the final part of this talk, we will briefly outline important physiological concepts including pulmonary hypertension, cyanosis, ventricular failure and arrhythmias. Pulmonary hypertension is defined as a mean pulmonary artery pressure at rest of more than 25 mm mercury. Precapillary pulmonary artery hypertension is due to exposure of the pulmonary vascular circuit to systemic arterial pressures, for example in a large shunt. Pulmonary artery wedge pressure is less than 15 mm mercury, and pulmonary vascular resistance is greater than 3 Wood units. Postcapillary pulmonary hypertension is due to left heart disease, for example obstruction of pulmonary venous drainage or high left atrial pressures in congenital mitral stenosis. Pulmonary artery wedge pressure is greater than 15 mm mercury, and pulmonary vascular resistance is less than 3 Wood units. The stimulus for development of pulmonary hypertension is the exposure of pulmonary vascular system to abnormal pressure and flow. This results in increased muscularity of the small pulmonary arteries, small artery intimal hyperplasia, and scarring and thrombosis. Ultimately, these changes elevate PVR and reduce pulmonary blood flow. In addition, the increased muscularity enhances the response of the pulmonary vasculature to pulmonary vasoconstrictors. The prognosis of pulmonary hypertension is closely related to right heart function. It is poor if the right ventricle fails and dilates. It is important to be familiar with the interventions that will alter PVR in the CHD patient, as alterations in PVR are an important determinant of shunting. A combination of high inspired oxygen, arterial oxygenation higher than 60 mmHg, carbon dioxide levels of 30 to 35 mmHg, a pH of 7.50 to 7.60, and low inspiratory pressures without high levels of PEEP will produce reliable reductions in PVR. Blunting of sympathetic outflow during a stress response also attenuates increases in PVR. Pulmonary vascular resistance is lowest at lung volumes at functional residual capacity. At small lungs volumes, atelectasis results in the compression of extralevelar vessels, whereas at high lung volumes, hyperinflation of alveoli results in the compression of intraalveolar vessels. Hence, in certain instances where PEEP works to recruit atelactic alveoli and increase arterial oxygenation, a decrease in PVR is generally seen. Pulmonary vasodilators such as PGE1, nitroglycerin, milrinone, sodium nitroxide also induce systemic vasodilation. Inhaled nitric oxide and prostacyclin are valuable selective pulmonary vasodilators. If a patient has postcapillary pulmonary hypertension, the use interventions, particularly the use of inhaled pulmonary vasodilators, may result in worsening of interstitial pulmonary edema, with little or no effect on pulmonary arterial pressures. Cyanosis is due to right-to-left shunting, low pulmonary blood flow, or low cardiac output. The level of cyanosis is dependent on the total desaturated hemoglobin concentration and occurs when the quantity of deoxyhemoglobin is greater than 50 grams per liter. It can be diagnosed late if there is anemia. Cyanosis can result in a high thromboembolic risk due to increased mass and rigidity of the erythrocytes and hyperviscosity. There may be impaired coagulation due to a decrease in von Willebrand factor and vitamin K-dependent clotting factors, primary fibrinolysis, and a decrease in platelet functionality, resulting in a high risk of hemorrhage. Cyanosis may also result in systolic and diastolic ventricular dysfunction, and a risk of infection such as endocarditis, brain abscess, and pneumonia. It may also cause renal dysfunction due to hypoxemia. Patients with CHD may also have ventricular failure. Ventricular dysfunction is linked to several phenomena. There may be ventricular remodeling due to heart defects such as a single ventricle. Prolonged duration of life before correction causes a greater degree of remodeling. Pressure overload is less well tolerated than volume overload as it leads to concentric hypertrophy, excessive wall tension, and inadequate coronary blood flow, causing ventricular dysfunction. Cyanosis can result in reduced myocardial perfusion pressure due to shunting and microvascular occlusions caused by hyperviscosity. Chronic ischemia due to malformations, surgical corrections, and cyanosis can also result in ventricular failure. The signs and symptoms of cardiac failure differ with age. Tachypnea, tachycardia, sweating, and cool peripheries are common to all ages. Additional signs in infancy include poor feeding, failure to thrive, hepatomegaly. In patients with congenital heart diseases, heart failure most commonly affects the right ventricle because of a volume overload, such as a left-to-right shunt, or pressure overload such as in pulmonary arterial hypertension. Volume overload is well tolerated for a long time, but entails a high risk of refractory ventricular arrhythmia. In pressure overload, patients become symptomatic if the pressure of the right ventricle exceeds half of the systemic pressure. Arrhythmias are very common and may be an intrinsic feature of certain defects. For example, some children have two AV nodes, AV block is common, and WPW syndrome is linked to Ebstein's anomaly. It may also be linked to surgery, for example AV block after perimembranous VSD correction. Arrhythmias occurring in children during surgery must be treated aggressively as they have a strong tendency to deteriorate into malignant arrhythmias. Also, as discussed before, cardiac output is highly dependent on heart rate in children. Both bradycardia and tachycardia can reduce cardiac output. The most common atrial tachycardia is junctional ectopic tachycardia, which is observed exclusively in children after cardiac surgery. It is due to an automatic discharge from the AV node or proximal bundle of His, with a ventricular rate that is higher than the atrial rate, more than 150 beats per minute. It presents as fixed narrow complex tachycardia. Although JET is highly resistant to traditional antiarrhythmic treatments such as adenosine and cardioversion, it generally responds fairly well to overdrive pacing if the heart rate allows for it. It may be sensitive to amiodarone, procainamide and magnesium. Ventricular tachycardia is always dangerous because it easily degenerates into ventricular fibrillation, compromises cardiac output, and is a sign of an abnormal myocardium. Bradycardia includes sinus bradycardia, AV blocks and bundle branch blocks. A pacemaker if the heart rate is less than 70 in children younger than 2 years and less than 50 in for children aged younger than 10 years. Thank you for listening to this lecture. Please test your understanding with the following multiple choice questions.